and constellation cycle and also loop cycle. Smoking active smoking have effect on fertility. And as it has the tuberculosis glands to infertility shall increase the risk for ectopic pregnancy. And it also decreases aromatase function and as it disrupts the meiosis and even it does not and so that with all moderate consumption of it is there is increased levels and increased progesterone levels. And stress factors there is increased cortisol levels, which inhibits the release of GnRH released from hypothalamus. So one needs to general examination from head to toe and any surfacism. For a female partner, it needs documentation. So, the recommended test from the history, you can know if the cycles are regular, you can predict that 99% of the times they are ovulatory. And but 1 to 10% there may be chance of an ovulation, and also even though cycles are regular, features associated with the possibility of ovulation progesterone, which is done 1 week after ovulation or 1 week before the expression census. Doing these stimulating hormone estimation, and thyroid disorder lead to release and which is after 30 to various markers, the image that is manipulated hormone and natural the sensitive and reliable markers of awareness according to ASRM and even ISHRE. And AMH, as we know that it is independent, can be estimated any and 2 to 5 cycle before the appearance of dominant follicle. So this is the table showing the low prognosis groups, that is the identification, which was based on markers of ovarian reserve and also the age. And also they have taken previous ovarian response to ovarian stimulation. So they have taken the ovarian markers as AMH less than 1.2 or equal to 1.2 as low prognosis and low reserve, and antigen follicle count less than or equal to 5. So one need to evaluate even the fallopian tube patency. The routine test we all know that it's program and contrast sonography. The clinical test has the prostate activity, the species, and the false positive results. Even though that is gold standard, but it's not only recommended only to test for tubal patency. And one need to evaluate any uterine lesions that can affect the fertility. Her fertility has to be ruled out, usually by transvaginal sonography, either it is 2D or 3D, and SIS and HSG, and hysteroscopy, which is the gold standard. MRI, which is not routinely indicated, but one going for any surgery like deep endometriosis or going for myomectomy from fibroid mapping, it is recommended, but not routinely recommended. And these are the second of the tests which are not routinely ordered. Only in particular situations or clinical scenarios we go for all this testing. One is laparoscopy for unexplained infertility and DFI and postcoital testing, which are not routinely recommended, and thrombophilia testing and immunological testing, karyotyping, are not done routinely. So, of all the causes, the anovulation or the ovulatory disorders, it contributes up to 25 to 40%, of which 70 to 85% are due to PCOS, and the other contributes to 15%. And the WHO has classified anovulation into 4 groups, and group 1 constitutes the hypogonadotropic anovulation, where it can be due to functional causes. One need to rule out the functional causes like excessive exercise or weight loss, or it can be due to drug induced due to anabolic steroids. So one need to rule out the functional causes, and then we need to rule out the tumors in hypothalamus or pituitary, or congenital hypogonadotropic hypogonadism, that is called. So they need to treat the cause, and in case of congenital hypogonadotropic hypogonadism, that is in Kalman syndrome, the ovulation induction is usually induced by gonadotrophins. And in this particular congenital syndrome, Kalman syndrome, even the puberty should be, induction of puberty should also be done. Usually the GnRH pump that is available or gonadotrophins are used. Coming to the group 3, it is ovarian failure, whether it can be due to genetic causes or it can be due to acquired causes. And in case of premature ovarian insufficiency, in 5% of the cases, you can see the follicular activity. In such cases, we can go for IVF, but prognosis should be explained. And if there is no follicular activity, the donor, one should opt the couple for donor oocyte. So the group 4, they categorized into hyperprolactinemia. So whether it is drug induced or due to the secondary to hypothyroidism, one need to rule out. And coming to the PCOS, as 70 to 85% contributes to anovulatory disorder is contributed by PCOS. The diagnosis is usually by the Rotterdam's criteria. Among the 3, the 2 should be satisfied. And in the ultrasound diagnosis of PCOS, the guideline says the TVS, transvaginal sonography, is preferred if woman is sexually active. And the endovaginal transducer frequency should be at least 8 megahertz or more than that. And with that transducer, if the follicular number per ovary is more than 20 of either ovary, and or ovarian volume is more than or equal to 10 ml, and we need to ensure there are no corpus luteum or cysts or the dominant follicle. So when there is an ovulation due to PCOS and patient wants to conceive, yes, the lifestyle intervention has to be suggested, and the first choice being the oral agents, that letrozole, and CC can also be given. And along with these oral agents, adjuvants can be given, and if there is no ovulation, oral agents, the second line would be the trophins, the patient has to frequently visit the clinic. So the patient compliance, we are opting for gonadotrophins or offering gonadotrophins. So if the patient compliance is poor or less, one can go for lap ovarian drilling as a second line of treatment. So and if there is no ovulation with the second line, then so the lifestyle management about this, and in PCOS, when it is associated with obesity, one needs to have the weight reduction using the exercise and dietary strategies. And the exercise, it is about 10,000 steps which we should offer the patient, and which includes daily activities and structured exercise. It improves the ovulation rate and it reduces which is system, and there is in when the distal tubal block. And this tubal disease, again, they have categorized into prognosis patients, and where the reparative tubal surgeries can be done, like laparoscopic, plastic, or the is 3 centimeters and should also be ruled out. In such cases, the reparative tubal surgeries can be done, but the recurrence of reocclusion has to be excluded, and the chance of risk of ectopic pregnancy is also increased. So one need to go for early surveillance when these tubal surgeries are done if the pregnancy test is positive. And in case in bad prognosis patients, one need to go for proximal tubal occlusion followed by IVF, and usually the proximal tubal occlusion or by laparoscopic salpingectomy is preferred. And previously, the salpingectomy is thought to reduce the ovarian reserve, but taking care of the vessels in the mesosalpinx, we can avoid this complication, and doing the dissection close to the tube, we can avoid this complication. Coming to the sterilization reversal procedure, yes, the microsurgical anastomosis can be offered in a set of patients where, again, the age is very important. Age and other factors should be ruled out, and the site of anastomosis is also very important. The isthmo-ischemic anastomosis has good prognosis. And yes, the risk of pregnancy is again 4 to 8% versus 1.4% in IVF. Surgical skills who are expertise in laparoscopy in future areas, we can go for microsurgical anastomosis, or if the age is more or any other factors are there, one need to go for IVF. So a word about this endometriosis. In stage 1 and 2, where the mild and minimal disease, according to Eshe, the operative laparoscopy could be offered, but is not, as it increases the ongoing pregnancy rates. But one need to consider her age and preference, whether there is presence of pain or absence of pain, and the male factor has to be evaluated, and good ovarian reserve. And the EFI is the endometriosis function infertility index has to be calculated, and other factors of infertility has to be ruled out, and she has any previous history of surgeries. One has to consider all this because the laparoscopy could be offered, but it is not recommended in all cases. And so one can, if at all the laparoscopy has done for other purpose and came to identify the lesions, one, without leaving them, we should eliminate the lesions. And regarding the expectant management, can we go for expectant management? She says instead of expectant management, the IUI is preferred. And ART, yes, if the other treatments failed or already failed, and there is a male factor and decreased ovarian reserve, one should go for ART procedures. Regarding stage 3 and 4, yes, the operative laparoscopy is not recommended as it does not improve the reproductive outcomes. But if the patient has pain, in such cases it is recommended, but for infertility alone it is not recommended. And with the IUI, the says the value is uncertain whether it improves the fertility rates. So the usually in stage 3 and 4 ART is considered. So regarding fertility preservation, usually fertility preservation is offered those who are going for chemotherapy or radiotherapy for malignancy. But in case of endometriosis, when there is extensive bilateral ovarian endometriosis, extensive disease, we have to offer them fertility preservation. And when there is a risk for multiple surgeries, we need to consider the fertility preservation. So the fertility preservation, it can be in the form of oocyte or embryo cryopreservation. If it is not possible, ovarian tissue cryopreservation also can be done. So the counseling, which is very important in the fertility when we are offering the fertility treatments or dealing with infertile couple, and it is the professional assistance that we give to the couple so that they come out of their problem and take their own decision regarding the fertility treatments. So regarding the counseling, one need to give before, during and after treatment, and so the patient-centered care, which includes the information gathering in previous history and analyzing and coming to the diagnosis, and the couple needs to take the decision, and support counseling is needed because most of the times the couple, they avoid friends and we are only the support system for them. So, and crisis counseling, yes, it is needed when there is IVF failure or any miscarriage, one need to give the counseling. And when the patient is in severe depression, one need to refer her to the psychotherapist. So what are the take-home points? Yes, the female partner evaluation should be started depending on the age, duration of infertility, and any previous disease or surgeries. And the evaluation of both partners should begin at the same time, and one need to evaluate tubal patency, documentation of ovulation, ovarian reserve assessment, and need to rule out uterine and endocrine factors. And infertility treatment options, they depend on woman's age, duration of infertility, and the male factor, and the extent of disease and previous fertility treatments. So that's all my talk. Thank you very much. Thank you for your patient listening.
Thank you, Dr. Deepika. If someone has questions, probably you can ask her now, or probably we'll park it later. Any which ways, yeah. I would now request Dr. Sujatha ma'am to kindly come and deliver her talk.
Has, a very good evening to you all. I would like to thank you all, first of all, for supporting us at Oasis for the last 12 years. And once since I started in Vijayawada, I've been coming to Ongole very frequently till the pre-COVID times, and you've always been having a warm welcome, and at the same time you've been supporting us. I hope you would continue extending your support here in Ongole, and this was the driving factor for us basically, because I did not want the patients who are reaching us, the distance should not matter, and they should not have a concern about reaching out and delaying their fertility treatments. With that intention, we had started at Ongole today. And in this session today, I will be discussing about managing the male partner in assisted reproduction. And Dr. Deepika has very elaborately discussed about the female factor, and we have been routinely doing female factor evaluation in our clinics. And when it comes to the male partner, about a couple of years ago, most of the times we only used to have the female coming to the clinics with a mother-in-law, and now with increasing awareness, we do have a male partner accompanying the female to the clinic, and both of them come as a couple. And we need to raise this awareness about the couple visiting us for fertility treatments together. So in this session, I would like to outline the appropriate evaluation and management of male in infertile couple. And also we should be able to, with this knowledge and with this awareness about management of male fertility, hope you would be able to provide the optimal patient management and give them the optimal success rates. So the male fertility evaluation and treatment starts with appropriate history. As a physician, we do take an appropriate history, and the same thing holds good even for the male partner. And after the history, we need to look at, in this session, I will be discussing about what are the things we need to look in history, in examination, when to offer the diagnostic treatments, and where are the diagnostic modalities applicable, role of semen analysis, what we need to look into it, what are the various medical therapies that can be offered, role of how do we need to counsel if they have to go for surgical procedures, and role of ICSI and IVF in this couple. So as we have been already aware of, infertility refers to inability to conceive after they are able to try for conception for at least 12 or more months of having regular unprotected intercourse. We do know that about 85% of couple conceive in the first 1 year, and another maximum 5% more would conceive in the second year, and we are only left with 10% of couple who are reaching out for us for fertility treatments. And in this part, when we divide the cause, where is the cause and what are the reasons where we need to evaluate, initially we thought that it was female was 30%, male was 30%, and both of them combined is 30%, and 1/3 is the factor which is the contribution from the male partner. But now we do see an increase in rising trend towards the male partner and male factor as an infertility issue, taking into the various lifestyle changes that are happening overall. We need to understand that male partner is contributing a lot to the cause of infertility, and it is increased to as high as 50%. So this is the reason why it is important in evaluating them. And when should we say that a male person or a male factor infertility? When do we say that they are having infertility? Is it because when there is a low sperm production, abnormal sperm functions, abnormal sperm motility and morphology? So when you notice these on a semen analysis, that gives us an idea that they are going to have a male factor infertility. But did we know that the causes of infertility can be further divided into those which are identifiable and reversible? So where you can identify the cause and you can reverse the cause so that they can improve their sperm count and they can have a chance of having a pregnancy, in such as, for examples, in terms of ductal obstruction, or in terms of obstructive azoospermia, where there is an infection which is blocking the ejaculatory duct, and where you can reverse it in terms of offering them with ART treatments. Hypogonadotrophic hypogonadism is one entity where we can, if we can identify them, it can be treatable, and most of them have successful pregnancies with self sperms. And there are conditions where the causes are identifiable and treatable, but they are not reversible. In terms of testicular atrophy, which has occurred because of viral orchitis in the childhood, they might have a testicular atrophy which may not be reversible, but still we can offer them with microsurgical testicular extractions, where a part of the seminiferous tubules may still be functional, and then they can end up in having a successful pregnancy. Sometimes, even though we do not identify the cause and we do not know what has to be offered to them to treat, it still accounts to idiopathic male infertility, which accounts to as high as 30%. So here we need to just give them empirical treatment for a couple of months and then move ahead as early as possible to the ART treatments. We do come across semen analysis where the report is quite normal, good volume of sperm which are present, somewhere around 100, 120 million per ml of sperm may be present, but these sperm may not have the function to have the ability to bring about the necessary, which is necessary for fertility. So this is where everything will be clear, like you will be trying to treat the female partner since the sperm count is normal, but still they are not conceiving. So the importance why I am dividing this into these particular division of identification is we need to set our goals and ideas of where and when to stop your fertility treatments and move to the next step of advanced fertility treatments. Male infertility is one scenario where the results are very good and the success rates are very high, and if you go for advanced fertility treatments and ART, they do have a successful outcome. However, we need to start with the less invasive treatments like offering them medical therapy, then a couple of months and then move forward, and it should not be like years and years of treatment with empirical and medical management. Even in an azoospermic patient, excuse me, azoospermic patients where the count is zero, repeated semen analysis is showing that there are no sperms which are seen. They do have some amount of sperm which is being produced in the testes, and they do benefit with ARTs and surgical sperm retrieval, and there is some amount of active sperm which is produced. So we need to always look at offering them with a surgical sperm retrieval before terming them as azoospermia. Also, we need to identify the conditions. Most of the times, when we are looking at evaluation of the male partner, we are looking at a semen analysis. We know that the semen analysis is abnormal. Why is it abnormal? When you are able to identify the cause. Sometimes even you do not identify the cause, but the count is less, low sperm, low motility, abnormal morphology. It should give us an idea that there is an overall health issue which can also be a matter. These abnormal sperm counts can end up, they may have obesity, they may have diabetes, they may have hypertension, which may result in long-term complications and side effects to the patient itself. Sometimes when you are looking at a semen analysis, we may also be looking at some conditions of genetic predispositions where it may be affecting the offspring as well. Sometimes in terms of where you have the CFTRA gene mutations, where there is an absence of VAS, it can run in the next generations if we continue them with an ART treatment. So genetic abnormalities, lifestyle and age factors that may affect the health of the male patient and offspring have to be looked into and always counseled before we are offering them the ART treatment and giving them a pregnancy. So with this overview, let us look into what evidence says in terms of what are the guidelines say in terms of practicing our male fertility management. So whenever we are doing an initial infertility evaluation, it is a must that we encourage that both the partners come together and have a concurrent assessment as highlighted by Dr. Deepika as well in her talk. So the initial evaluation of the male partner should include a reproductive history in terms of any previous pregnancies. If this is a second marriage, any pregnancies in the first marriage, any problems with sexual difficulties, intercourse difficulties, ejaculatory dysfunctions, premature ejaculation, all these loss of libido, everything in detail has to be looked into. Also, we need to analyze this history taking in terms of any lifestyle factors which may contribute to the male factor infertility. Also, whenever we are doing a further evaluation, the first basic test which we have been taught is the semen analysis, and it continues to be the first basic investigation in the male partner infertility. And never go by one single test of semen analysis. It is always advisable to have more than one test. It's a strong recommendation to have one or more semen analysis before offering them with the fertility treatments. So whenever you're looking at the semen parameters and the semen analysis which is abnormal, where you find that the semen analysis is abnormal in terms of motility morphology or the count, you need to have a presumed male factor infertility even in terms of history. It is always advisable to have an examination and evaluation of the male partner with a male reproductive expert and have a complete examination of the patient, where we need to look at the physical examination and the reproductive examination, look for the testicular size and the descent of the testes, any varicocele, any infections have to be looked into. So what are the other indications where you need to have the male partner to be evaluated by the reproductive expert? Failed ART cycles, recurrent failed implantations, recurrent pregnancy losses, a male factor has to be thoroughly examined, and we need to evaluate whether there is a cause from the male side. Whenever we are evaluating, age plays a very important role, both in female as well as in the male partner. The younger they come to us for fertility treatments, the best is the success rates. So we need to encourage the couple, and in our clinics, we need to create awareness in couple reaching out to us for fertility treatments. We need not push them to go for a fertility treatments, but at least we should encourage them to try and conceive naturally as early as possible. Even in the male, it is surprising that the testosterone levels drop by 1 to 2% per year after the age crosses 30 years. And by the time 40 years of age, there will be lots of sperm abnormalities and aneuploidies, which can result in the offspring having later on long-term health issues. So age is a very important factor, and we need to assess this whenever they come to us. Coming to the lifestyle factors, obesity and other lifestyle factors, excessive weight gain has been found to have an impact on the male factor infertility. Excessive smoking can lead to poor sperm morphology. Men who drink alcohol heavily also have low sperm counts. Also, surprisingly, excessive coffee consumption also can lead to further reduced sperm concentration and count. So we need to inquire and take an evaluation and history of even this history of smoking, alcohol and caffeine intake. Excessive intake of red meat also has low implantation and can result in reduced pregnancy rates. Not getting enough vitamin B and vitamin B12 also have an impact on the male fertility, with more and more of indoor work from home and staying at home, not going out into the sunlight. About 60 to 80% of the population are ending up in vitamin B deficiencies nowadays. So intake of junk food, stress, infrequent intercourse, loss of libido, all these needs to be inquired into whenever we are looking at lifestyle as a factor for infertility. So what evidence says in terms of lifestyle, and what we need to be looking at is, we need to always look at lifestyle factors and how these lifestyle factors, medications, age, their environmental effects have an associated component in male factor infertility. 80% of the correction from the male side in changes in lifestyle factors and 20% contribution from us as clinicians can improve the chances of their success rate. Clinicians should also counsel that abnormal semen parameters are associated with abnormal health. They're not in a healthy lifestyle, so they may have long-term risks associated with these abnormal sperm production. So coming to the next evaluation is in terms of semen analysis. There are lots of changes which have come across over a period of years on the semen analysis. We have the latest WHO 2021 semen analysis guidelines where it says the volume is 1.5 ml. Semen concentration should be 16 million per ml. The total sperm count is about 39 million and total motility of 42% and total progressive motility of 30%. Vitality 54% and normal forms is 4%, normal morphology. So we need to encourage the couple to have semen analysis done at a designated laboratories where they follow these criteria of uniform criteria or a standard criteria, not just reading the slide and giving the value and an approximate value. At least a minimum of 200 sperms have to be looked into, and the count of 200 sperms is required to go and to get an adequate analysis. When we look at analysis, what the results say or evidence says that there is a greatest significance of a semen analysis being abnormal if you find multiple abnormalities, like if there is an oligospermia and a teratozoospermia, there is definitely a problem with the overall health of the person which is affecting the sperm count. So this needs to be looked into. Hormonal evaluation including FSH and testosterone levels have to be considered in the male partner where there are symptoms like loss of libido, erectile dysfunction, and where the semen analysis shows oligospermia or azoospermia or atrophic testis. So this hormonal examination is only advised when you find that there are these symptoms and not as a routine basis. Whenever there is a hormonal evidence of hormonal abnormality on evaluation, also we need to further look at these testosterone levels. When you do the semen analysis and we find that there is an azoospermia or a severe oligozoospermia of less than 5 million, this is where we need to offer them with karyotyping, and Y-chromosome microdeletion should be recommended in these women, in these men, where there is also whenever you find elevated and low testosterone levels, also we need to recommend this karyotyping and Y-chromosome deletions. So to summarize on the semen analysis, normal normozoospermia patients, normal semen analysis count with a positive history or abnormal physical parameters or symptoms, and designate that they could be male factor infertility, where they have multiple failed ovulation induction cycles. We need to offer them ART as a condition for fertility treatments. Patients, we need to look at hormonal evaluation to rule out for obstructive and non-obstructive causes. The testosterone and deficiencies are normal, you would be looking at obstructive azoospermia, and if it is abnormal, non-obstructive. Whenever you look because these obstructive non-obstructive parameters in the semen analysis, we can retrieve surgical sperm retrieval and microdeletion. However, if there is a microchromosome microdeletion, we need to expect prognosis that the offspring may continue to be azoospermic and they may transmit if it is a offspring. So what is the role of sperm DNA? Sperm DNA plays a very important role in placental formation, and also placental health is crucial for the fetal survival. Why is it important in terms of sperm? As a DNA, all the cells have DNA in our body. So if you look at this picture where you see the somatic cell DNA and comparison with the sperm cell DNA, majority of the sperm is DNA. Because of formation of environmental exposure, smoking, toxins, etc., this damage is more evident on the spermatozoa than on the somatic cells. So the first cells to get spermatozoa, these radicals keep on attacking these cells, the sperm, and cause damage to the DNA. So we need to have a balance between these reactive oxidative species. So that is where antioxidants in supplements and diet come into place. So in normal physiological conditions, the sperm produce a very low level of free radicals to fight against just the microorganisms. But if there is any environmental toxins or exposure to the environmental toxins or smoking, etc., can result in production of higher concentration of these free radicals, which can result in damage DNA, which can result in having a negative pregnancy outcomes. So the role of antioxidants will be in fighting and fighting with these free radicals. Vitamin C is one of the most potent antioxidant which is available. So antioxidants in terms of vitamin C, vitamin E and zinc can play a role in preventing this sperm DNA damage. So how long should we give this antioxidant? For 2 months. So what evidence says in terms of DFI and DNA damage? So sperm DNA fragmentation analysis is not routinely recommended as an initial evaluation for all infertile couples, though we do find that it can be because of the toxins, but it is recommended in couples where there are recurrent pregnancy losses, recurrent implantation failures, and where you find that there is a problem with the pregnancy loss. So because this sperm DNA damage, if loss, that is where we need to add this issue. Role of imaging in imaging. Ultrasound should not be routinely performed as an initial evaluation of infertile couple. Routine imaging for looking for or diagnosing for varicocele is not recommended when there is no clinical evidence or clinically palpable varicocele which is present. So the role of imaging lies only, and looking for a varicocele lies only when you have a clinically palpable varicocele. So what evidence is for varicocelectomy surgeries? Surgical varicocelectomy should be considered in a man who is attempting to conceive, who has only palpable varicoceles and infertility and abnormal sperm parameters. However, there is that we should not recommend varicocelectomy only when looking for a varicocele which is found on an ultrasound scan. So we should never treat the ultrasound, we should be treating the patient and a clinical finding. For men where there is a clinical varicocele and a non-obstructive azoospermia. So varicocele is the reason why we are looking at varicocele is because it is going to increase the temperature of the testis. So thereby the sperm which are produced are going to be dead because of the temperature. So there should be sperms, but it should not be azoospermia. Azoospermia, we need to look for other causes like whether there are any testosterone levels which are low. So correcting a varicocele in an azoospermia patient might not be beneficial. Improving the sperm. Those who are having non-obstructive azoospermia benefit with a surgical sperm retrieval than going for a varicocelectomy prior to the surgical sperm retrieval. This is what evidence is. So looking at, so there is no role for varicocele repair in azoospermia couple patients. So coming to the medical interventions, what are the medical interventions that we can offer? The antioxidants. So whenever you find a low sperm count, total motile sperm cells is what we are looking at, and total motile sperm count which is on the lower side, rather than offering them with an IUI treatment, they benefit better with an IVF ICSI treatment. That is what the expert opinion and evidence is. Use of aromatase inhibitors, HCG, selective estrogen receptor modulators, or a combination of these medications in infertile women with low serum testosterone levels can be tried to improve the testosterone levels. So this helps especially in those who have non-obstructive azoospermia. However, there is limited data on use of these medical interventions prior to going for a surgical intervention. Hypogonadotrophic hypogonadism is one condition where medical interventions have a role, and if you can determine the etiology cause of this gonadotrophic hypogonadism and offer them with medications, they do produce sperm and do have successful pregnancies. There is no role of testosterone. When you find low testosterone level, you should never supplement them with injections of testosterone. Testosterone levels, this is going to cause a mental effect on the outcome. So what are the various medical interventions that can be offered? Depending on the testosterone levels and the FSH levels, we can look at HCG, HMG. And online update can come 3 to 24 months depending on the monitoring that is needed. Those undergoing these medical interventions need very close monitoring of the hormonal profile. Otherwise, you may be suppressing the testosterone. Long durations, we do come across patients who will be using durations of hormone citrate. There will be improvement in the count. We shouldn't be looking at the count has improved, so let me continue for some more days. Where the counts have increased, try to retrieve those sperms, see that they conceive as early as possible and complete their fertility journey within 3 months. So coming to surgical sperm retrieval, which is testicular sperm aspiration, it is indicated in azoospermia, obstructive or non-obstructive, and those patients where there is failure to ejaculate during an IUI or an IVF cycle. Total asthenonecrosospermia is where they do benefit with TIGSA, and failed IVF cycles and recurrent implantation failures with the raised DFI benefit testicular sperm aspiration. So this is a surgical procedure where we retrieve the sperms directly from the seminiferous tubules under anesthesia, and these sperms are processed in the laboratory, and we can use these sperms only for a procedure. There are other interventions which are being looked at to reduce the sperm DNA fragmentation in terms of magnetic activated cell sorting system, where we are looking at the damaged sperm. So where the sperm DNA is damaged, these sperms membrane integrity is lost. So which is an early apoptosis. So when membrane integrity is lost, the phospholipid serine is exposed. So this magnetic cell sorting system uses a technology where the magnets are attached with adhesive 5, which has got the affinity for this phosphatidylserine. So those sperms which are damaged get stuck to the magnets, and the normal sperms which are not damaged come out of the chamber. So when you use these sperms which have got a normal DNA fragmentation and those which are not going for apoptosis, we can improve the success rates of those pregnancies. Microfluidics is another technique where we are using, we have now started using with very good, excellent results. And this again uses the same technique where there is a laminar flow in the middle, and the sperms which are motile with less DNA damage come to the chamber C, and which we can take them out and use them for the fertility treatments. We have noticed at Oasis an outcome of a clinical pregnancy rate as high as 79% with usage of this cell sorting techniques, and we're able to offer this to the couple who approach us. So what is the future? Where does the future lie? We do know that the gene cards list of more than 3,600 gene defects are associated with human male infertility, and another 3,200 plus genes are associated with genitourinary birth defects causing abnormal male reproductive development and function. So these many genes, 3,200 and 3,600, are implicated as a cause of male factor infertility. So this is where now we are having a new research techniques in terms of next generation sequencing and whole exome sequencing, which are able to identify any microdeletions or loss of these genes which could be attributable to the male factor infertility. So this is where the future lies, and the potential impact of these genetic findings would help us in explaining the couple who have these sperm factor abnormalities. Most of the times they tell us, my count is normal, only motility. Why is it that my motility is low? Even though I don't drink, I don't smoke, I don't have habits, I don't have stress. So we don't have an answer. This is the answer for that question, where the genes are implicated, which are getting lost during the process of progeny development. So sometimes there would be genes which are lost in areas where they can result in estenozoospermia with multiple abnormalities in the sperm fasciola and primary ciliary dysfunction. So how much ever you try to have them go for an IUI or a natural conception, they may not be successful. However, we can offer them a good success with an ICSI treatment. So this is the reason why I again further emphasize in the end that their fertility journey should not prolong more than 3 cycles of IUI. If they're not conceived, offer them another 2 to 3 cycles and then let them move to the advanced fertility treatments like IVF and ICSI. So today the knowledge is this knowledge of genetic genes. I would hope that you would be using to counsel your patients on how successful the ART treatments lie and not why all patients are successful. So we also can look at advanced fertility treatments in terms of PGTA genetic testing, and also the future looks promising in terms of improving the health and fertility through precision medicine application and application of these advanced technologies in cell sorting and in pre-genetic testing of embryos. So to summarize, whenever you're looking at evidence in evaluation of the male factor, you need to have a basic evaluation. The first is semen analysis. If they find any abnormalities in the semen analysis, go for a physical examination with an reproductive expert and look for multiple abnormal parameters which is alarming, and antioxidants for 2 months. Good option of medical therapy in terms of normozoospermia, which is idiopathic, or oligozoospermia with low testosterone levels. There is no role for testosterone therapy. ART ICSI is better than IUI when there are low total motile sperm count. Surgical sperm retrieval is good procedures and advancements reducing in terms of cell sorting techniques and microfluidics do help us in offering them the best success. Male fertility is one thing which is we are able to get the highest and the best success rates. So only thing is we need to identify them. Let's not think that male partner evaluation is not in our armamentarium. Do treat the couple as a whole, and then if you just are able to take the male factor, you're going to give them 70% success rate. Thank you very much for your time, though it is late. Thank you very much for staying back. We have the next talk with an interesting talk from Dr. Krishna over here. Thank you.
Thank you so much, Sujatha ma'am. I think we'll park the questions in the end. I think that would be better. I would request Dr. Krishna to kindly come over.
Quite late after the events, let's embark onto the journey of the gap in the laboratory. I will not take long. I'll keep it very short. Most of you gathered here are clinicians, but I think it's very essential and important that we have a thorough knowledge and insight as to what's happening in the laboratory. You know, it's okay for an embryologist not to know much about the clinical science, but the vice versa probably is not a good idea. So there we come. It's just a little overview of what the lab is up to. In 4 decades that first test tube baby was born, a lot of research has gone, science has developed in every direction. And where are we today in 2022? A quick glimpse what are the recent advances that's happened in the laboratory. There was a point where we thought all of this was a fiction. You know, we thought this shouldn't be done, this is not possible. But I think in 2022, evidence says all of that is possible, and we're proud to say that we have kind of gotten a lot of these advancements to every doorstep. You know, I think gone are those days where we thought that advanced treatments have been a cup of tea of the Western world itself. I don't think that's true. The technology is available for all of us. The technical know-how is there, and I think there's a technical snap. We are finding it difficult to download the. Sorry. But I think let's quickly, while Dinesh is helping us download the whole PPT, you know, Dr. Deepika and Dr. Sujatha did take us through a bit of the female and male side. So, you know, what's new? Where have we gone next with the female side? I think what's recent, what's been tried is fertility preservation. Dr. Deepika did give us a brief mention of that. Oasis, just not this year, for the last 12 years, has been offering fertility preservation. So we've been doing oocytes, sperms, embryos, cryopreservation for these patients who've been diagnosed with either malignancy or some medical condition which can put the ovary or testis at a risk. So fertility preservation is an option. And we've been helping a lot of individuals and couples who've been wanting to complete their dream of childhood. And now people who did not have which was so what is being testicular sperm normal? Should we be using it? Would there be lesser success? Would the child have some issues? And we did look at that. We compared the ejaculated sperm and testicular sperm ICSI cycles, and we did see that our outcomes were all comparable between ejaculated and testicular sperm. And we also looked at the neonatal and perinatal outcomes to see if there were some maternal complications or fetal complications. And again, our 10 years data was very reassuring to tell us that testicular sperm do offer a success rate which is on par with ejaculated sperm, and it is quite safe. So that's a quick general slide to take you all through with a little information. There's been that little myth that IVF conceived children will be normal. I think that's a question that even we are concerned about, but that's the facts and figures that you could quote with all your couples who come in for treatments. I think in IVF conceptions, the incidence of congenital anomalies is 9%, but in natural pregnancies, it is 6.6%. Statistically, that's no different. So the misconception that we have carried over the years that IVF conceived children come with higher incidence of anomalies is no longer true, and that's the facts and figures would say that they're equally healthy compared to a natural conception. So this, again, another thing, the routine practice that we all have done in the past, even as a med student, I have seen is when there's agiospermia, we send them to urologists, we do biopsies, we send for histopathology. If the histopathology comes back as normal spermatogenesis, we then send them back to the IVF centers where a repeat biopsy is needed. With cryopreservation developing so much, I don't think there's a need to do two biopsies. That when you send them to a urologist, it's good to check if there's a facility to freeze the sperm, or inform one of the IVF centers where an embryologist should come and pick the tissue up. Don't put it in formalin, put it in some HEPase-based buffer media. They can shift it to their IVF centers, tease it. If there's sperm, they can freeze it. So this is again our data of Oasis, which was published in Fertility Sterility, where we compared would frozen testicular tissue give us equally good results, and the answer is yes. Our live birth rates were no different between fresh and frozen tissues. So doing a testicular biopsy TISA for azoospermia, not looking at freezing them as a backup, I don't think we're justifying patients' time with us. We're not giving them the best treatment possible. Microfluidics and MAX, I think, again, published in Fertility Sterility, where we've shown that our clinical pregnancies and live births have been phenomenally good when we've used these things. So the last thing is about the laboratory. I'm going to end it up in the next 5 minutes. I think there's so much that's improved in the last 4 decades. Our understanding of what the embryo needs in the in vitro condition has phenomenally improved. I think the success rates in way back 1978 was probably around 6%. We've reached a point where 60 to 70% take-home baby rates can be assured to the couples. But will everybody need everything? Probably the answer is no. You've got to be individualizing patients and offering them, but there's so much that's improved. About the air quality, I think it is so important in at least a country like India, where even towns like Ongole, I think the air pollution is going up, and you have to be creating an environment that is conducive for the embryos to go in the laboratory. So just taking a room and taking an egg and sperm and putting in the incubator might not give you the best results. And this is where statistics and auditing your program really matters a lot. And air quality, there's so many papers which have spoken about the importance of air quality. If your air quality is going down, your pregnancies, your miscarriages are going to go up. Your pregnancy rates are going to come down. And there's this wonderful paper published by AIMS in Delhi, when it's the December-January month, where we all know that smog is a problem that India is facing in the capital city. And there's publication from AIMS which says that the pregnancy rates drastically fall down by 40% in those 2 months. Again, coming back to the normalcy. So Like, sometimes we have this myth of stopping cycles in summer. Actually, it's a myth. You don't have to stop any fertility treatments in the month of summer. Vijayawada, Ongole, there's a trend where you see cycles going down because people think summer is not a good month. There's absolutely no such thing in science which says that pregnancy rates go down. But in winters in Delhi, it's because of the pollution that's going up, pregnancy rates are coming down. So air quality is of paramount importance. And our knowledge about the incubators, culture media and all is so improved. Picking the best embryo, I think there's so much that is improved in the laboratory science as to how do we pick the best embryo. Because it's just not about letting the woman fall pregnant. It is also to ensure that it's a singleton pregnancy where the lady reaches the term and delivers and takes home a healthy baby. I'm sure as obstetricians, we've always hated when a lady has come back with a multiple or high order pregnancy just from an ART cycle. A natural conception, that's something that we can't control for a twin pregnancy. But if it's an ART, where I've put back 2 or 3 embryos and the ladies come back with a twin or triplet, we all know that's quite a nightmare and the morbidity is going up. So putting back a single embryo is what is the strategy at this point in time. Countries like UK adopted it and they've shown that the live births and implantations don't go down. Putting 4, 5 embryos will not give us the best reproductive outcome. You just have to pick the best embryo, and there's so much of science that has come up in the recent times. Growing them to blastocysts itself is a self way of where the embryo says, I'm the best, pick me up. The incubators now come with a time-lapse system where you actually can sit at home and work. I am married to an IT lady, and I hate it when she says I'm working from home. And because as an embryologist, I've never got that opportunity to do that. But now there's a camera that's fitted in my incubator. I just have to come do ICSIs and go home. And the information comes on my laptop. I just can look at the way my embryos are growing. It's such a bliss to see your embryos grow. They talk to you. If you have the patience to hear your embryos, the embryos have got wonderful stories to tell you. Do we have the time? Do we understand the language? And that's where the lab is all about. The science of laboratory is all about that. And there's so much that's improved. We did have a brief mention about PGTA, which is biopsying the embryo and understanding if your embryo is genetically normal. It's just not for people with single gene disorders like thalassemia or sickle cell. Nowadays, women with recurrent implantation failures or recurrent pregnancy loss, or in fact, we say to reduce the time to pregnancy. Most of us, I'm hoping, are in our early late 30s here, and I think we all belong to that fast forward generation. And so are our couples who are facing infertility who come to us who wanted everything. They don't mind have wasted 5, 7, 10 years, but when they land into our clinics next month, the UPT should be positive. I think that's the mindset all of us are going through, and I think PGTA can be one of those things which can help us reduce the time to pregnancy. So there's so much that's improved just to pick the best embryo. That would give you the best implantation, a singleton pregnancy, keeping in mind the morbidity and mortality, and ensuring the obstetrician also has a peaceful night's sleep. And this is where it all starts. I think we're going ahead next, I think artificial intelligence. Nowadays, everything what we're doing, we want artificial intelligence, fast forwardness. When the lady comes, she wants to know when will she be pregnant, what is the date, when will she deliver, will it be singleton? They want to plan so much. I'm like, why did you not plan pregnancy in the first 6 months? Jokes apart, artificial intelligence is going to be the future of ART and medical practice, which is helping us improve on the success in the future. I'll brush through the files, slides from here. I think pressure frozen embryo transfer. Frozen embryo transfers do give us better success rate because you're going to get a better uterine environment, and that's been our experience at Oasis as well. We believe in vitrifying our embryos and doing an embryo transfer, FET cycle or a frozen embryo replacement cycle. That's been our success rates, and putting one or day 3 or day 5, there's always been that confusion. Day 5 undoubtedly gives you the best success rates. Whether to put 1 or 2, I think I would always want to pick on putting one best quality embryo. Putting two is only going to increase your multiple pregnancy rates, and that's Oasis data. We're putting one embryo back, we had a live birth of 35. Putting two, we had a live birth of 46, but our multiple pregnancy with single embryo transfer was only 3%, but which went up to 23%, which is phenomenally higher number. How do we improve on implantations? Yes, we did speak about PGTA, but there's, I think, something called as embryo glue, which again is a chemical, which is hyaluron, which is shown to improve the cross-talk between the embryo and the uterus. So I think we do believe doing a lot of interventions for these women with recurrent implantation failure, and embryo glue is one of the things. Would laser help us and improve reproductive outcomes? The answer is no after 20 years of research. Right now, I think laser is only used for embryo biopsies. So PGTA is something that's helping women with advanced mental age, recurrent implantation failure, and even severe male factor infertility. And that's been the success rates of Oasis. A lot of happy couples who have gone home with babies who had failed in the past and published in the year 2019 in Human Reproduction. So did our RPL. So RPL, it's more about the idiopathic RPL. And there's so many times 4 or 5 miscarriages. We've done all that whole spectrum. The patient spent sometimes thousands, sometimes lakhs. Nothing's happening. PGT can be the answer. We're probably not picking up translocations or inversions in such women or such embryos. We probably are picking euploid embryos, and that could probably give them a better success rate for live birth. So I think the recipe for success is your laboratory. If you're wanting to really run a good infertility program, the success, the secret lies in your laboratory. If your embryologist is not doing a good quality control program, is not constantly looking at document control and taking care of the equipment, I don't think we will have the success rate. And it's a myth that the Western world is going to have a 60% success. India equally has shown, and at Oasis we have this, so it's time that you build up a good laboratory team as well, a good team of scientists. So I think it's all about innovations and everything, and we keep innovating, we keep adding to the science in India, and this has been our recent innovation. We implemented electronic witness system, because even in today's world where a lot of people are IT and they know technology is something that has reached every corner of India. But still there's that little thing they come and say, will you ensure that this is my sperm and my wife's egg? Is my wife carrying our own genetic child? This is a question we get to hear quite often. And I think that's right, it's their right. When they've come and paid so much, it's my duty as an embryologist to give that comfort to the couple that there was no mishap or mix-up. And electron witnessing system was something that we thought should be one idea where every step is electronically witnessed, stored, and in this treatment cycle, we give that summary to the patient where the patient feels absolutely confident that there was no mix-up that happened. So with that, I'll stop the session. That is what it's just a glimpse as to what the lab has emerged, and this whole success journey what we're talking about. I won't say it's not what we're doing with the man and the woman. Yes, that's the starting stage. They need to be taken care of, but the lab is equally important in ensuring we get the success rates as high as 60 to 70%. Thank you, everyone. But yeah, while we are having dinner, I think me and Dr. Sujatha and Dr. Deepika here, if there's any questions or anything that you people want, we'll absolutely be happy. Sorry, I got a bit delayed joining you guys in the beginning, but we wanted to get to every little and ensuring that people get treated in their comfort zones. And here we are in the city of Ongole, bringing the best of the fertility treatments. I'm hoping the message will be passed across loud to every needy couple. and we are hoping these advanced treatments reach everybody. Advanced treatments are not confined to Delhi, Bombay or Hyderabad. Now I think everybody can get an access to that. Thank you all. It was a wonderful evening with you all here in Ongole. Thank you.